Hello, everybody, and a very warm welcome to my monthly vlogcast. As you can see, sitting here with me on Zoom is Professor Claire Harrison. Claire, a very warm welcome to you. It's a very special treat for us to have you, and for me, to have you taking part in one of my conversations. The conversation this month is a really exciting one. Professor Harrison has just completed the MAJIC study for PV patients. And I have to say there's been a little controversy around this, and she's very kindly agreed to share with us today the contents of the study. This is so exciting, Claire, and I'm going to hand over to you to share your contents.
Well, thank you very much, Nona, and it's a great pleasure for me to be here to talk about this study, which has taken us 10 years actually to complete from start to finish and was recently published. Now, the study has got some messages about general management of PV and also some specific messages about ruxolitinib. And the study is called the MAJIC study. Well, there were two arms to this study, an ET arm, which we published about 6 years ago, and this arm, which is called MAJIC PV. Lots of people and lots of institutions were involved, and this was entirely a UK study. Just to introduce the study, I'm sure our audience doesn't need to know, but I thought it was useful to put this in context, and the context being the myeloproliferative neoplasms. And I know our listeners are well aware of these conditions, but maybe they're not so aware that there are many, many patients across the world living with an MPN. It can feel lonely as a patient, but there are actually many others living with these conditions. And as you all know, these are conditions that are currently, for the most part, incurable. And there are problems that patients must face: symptoms related to the disease, risk of blood clotting, much smaller risks of the disease changing, but also managing toxicity of treatments and when those treatments don't work. And that can be a little bit controversial. So there's a need for newer therapies and also ways to evaluate them. And when we say surrogate endpoints, we mean trying not to wait until a patient develops, for example, a blood clot or their disease changing. So we're looking for markers that can predict that. And if we affect those markers with a treatment, we can do trials much more quickly. And some background to the study: we know that PV, which is the focus of discussion from now on, is caused in almost 100% of patients by mutations in JAK2, and that patients, for the most part, have risks of blood clotting and bleeding events and symptoms, although some patients may have none of those. And some patients may have their disease transform, although the majority of patients do not have that problem. And so we focus our treatment on lowering risk of blood clotting, usually with venesection, removing pints of blood, and low-dose aspirin. And in patients deemed to be at higher risk of blood clotting events, usually those over the age of 60 or more recently 65, or having particularly high blood counts, we will use drugs such as hydroxycarbamide or hydroxyurea or interferon. And there's no evidence that this treatment does anything other than reduces the risk of thrombosis. And there's no evidence so far that it reduces the risk of transformation. Now, many years ago, over 10, myself and several other experts got in a room and drew up some criteria by which we could, in clinical practice, decide whether a patient in front of us is resistant or intolerant to hydroxyurea or hydroxycarbamide, because that's the most common drug. And the reason we did that was we could see that newer agents were becoming available, and we needed to try to decide when we thought it was appropriate to consider a patient for a newer therapy. Now, these criteria include things like having very low white count, or lack of ability to control the blood count, or persistent bad symptoms, for example. But they're not particularly evidence-based, but it does so happen that if you can identify that a patient is resistant to hydroxycarbamide for example, associated with anemia, then there is a 5-fold increase in risk of death for that patient. Since we drew up those criteria, we discovered the JAK2 mutation, and ruxolitinib was developed. And it was first developed, tested and approved in myelofibrosis, and then we went on and tested it in patients with polycythemia vera. And the drug was approved in about 2015 for PV patients on the basis of 2 studies, which were sponsored by the pharmaceutical companies Incyte and Novartis, who market ruxolitinib. Now, those studies led to the approval, but not necessarily reimbursement of this drug. But more importantly, they left us with questions because of the way the studies were designed, with patients crossing over to get ruxolitinib after either 12 or 18 months. We had no idea then about long-term benefits of that drug, comparing it properly to patients not on the drug over a long time period. And that's particularly important with diseases such as PV, when patients have the disease often for a very, very long time. So this slide just summarizes the study design. We randomized 190 patients purely from within the UK to either ruxolitinib or what we called BAT, which is best available therapy, which could be any one of a number of approved drugs, and for many patients still included hydroxycarbamide. Many patients had already received interferon, because we know that's a commonly used treatment, and many patients had either already had that as a first or a second treatment, and many patients had that treatment as a control treatment. What did we measure for patients, and what did we determine as outcome? Well, that's listed on the bottom half of the slide, which I'm hoping you can see. Here you can see control of the blood count, including reduction of spleen size, how long that control lasted as a secondary outcome, blood clotting and bleeding events, progression of the disease, survival of the patient, molecular responses, quality of life, and of course, safety and toxicity. This slide just shows you all the patients and their details from when we recruited them. And you can see there are 180 patients who went on and took the study drugs, and we knew what drug the patients were taking and they knew what they were taking. So it wasn't placebo controlled or blinded. You can see that many patients had had the disease for a long time, up to 388 months in some instances, and most patients had had at least 2 previous lines of therapy. There's a slight increase in previous thrombosis for the control arm, and there's a slight increase which balanced that in diabetes and hypertension or high blood pressure in the ruxolitinib arm. So we considered that they were well balanced, which is important when you look at endpoints. So what did we find? Well, we found some things we already knew, that patients who received ruxolitinib after hydroxyurea or hydroxycarbamide were more likely to get control of their blood count, deemed as a CR or complete response, and that response was more likely to last longer. All of ruxolitinib data here is shown in blue, and discontinuation of that treatment in the study was less likely to happen with ruxolitinib. For the purposes of this presentation, all the novel data that we found from this study is indicated by a yellow star, and here is one of them. So we found that event-free survival, which was freedom from big clotting or bleeding events, the disease transforming, or death, all of which I think we would agree are very important. We found that this was superior and prolonged with ruxolitinib compared to best available therapy. When we broke those different components of event-free survival down, you can see that ruxolitinib appeared to perform better for all of them, but this was only significant statistically, so when we apply a test of statistical significance, for thrombosis. And again, this is a completely novel finding. It's never been shown in studies with ruxolitinib before. If you look at individual components of controlling the blood count, you can see that it's particularly the red blood cell count, hemoglobin or hematocrit, that were well controlled. And we found that, importantly, because we know that venesections are difficult for patients, they take time, they cause iron deficiency, there were far fewer venesections, 84 versus 307 for the control arm. And we also found that the number of venesections a patient has were important, and they correlated with risk of thrombosis. And this has been controversial for a long time in this field. So we're already showing some important things relating to ruxolitinib, but for a long time now, there's been a lot of controversy about whether it is important just to control the red cell count with a drug like hydroxyurea or ruxolitinib or interferon, or is it important to also control the white cell count or the platelet count, i.e. achieve a CR or complete response? And in this study, regardless of the drug treatment, we found, as you can see here, that event-free survival, so freedom from clotting, bleeding, transformation and death, was better for patients who had good control of their blood counts. So getting control of the blood count in this study was important, as important as the drug that the patient received. So this is an important practice-changing finding, and important if you're a patient taking a drug therapy for PV, that you do look to try to control as far as possible all aspects of your blood count. We have also been interested, and were able to build into this study, some molecular analysis. So just a little bit of explanation for you. When we measure the quantity of JAK2 that a patient has in their blood, we express it as the JAK2 V617F, that's the mutation, VAF. And VAF stands for variant allele frequency. So it's expressed as a percentage. So if you have a VAF of 50%, then 50% of your JAK2 is mutated and 50% isn't. So what this slide is telling you is some of the data for changes and molecular responses in the MAJIC study. We found that at study entry, the median of VAF for JAK2 was not really different between the two arms, although it looks slightly higher for ruxolitinib. Over time, we saw that patients had a reduction in their VAF. About a third of patients had a 25% reduction, and slightly fewer had a deeper response called a 50% reduction. And this is what we then went on and called a molecular response, which is in line with international criteria. So at 1 year, between 14 and 18% of patients had a 50% reduction in JAK2. And later on in the study, again, something that wasn't done in the previous studies, we showed that that number increased for ruxolitinib treated and best available therapy treated patients. So that at the final evaluable time point, which was between 2 and 3 years, 56% of ruxolitinib and 25% of control arm patients had a 50% reduction in VAF. And this is shown in what this figure here, which is called a waterfall plot. Ruxolitinib treated patients here in blue, you can see there are more of them below the no change in the VAF line. For those of you who are wondering about interferon, because we know that this drug does reduce the JAK2 VAF, I can tell you that 11 of 13 interferon treated patients in the study achieved this reduction, and many patients with interferon had it as in a combination, but I'm telling you the data for 13 who only received interferon alone. Jennifer O'Sullivan, whose picture is shown here, was one of the team of people, including people whose names you'll recognise, such as Joanna Baxter, who first described the JAK2 mutation, and Jyoti Nangalia, who's been involved in a lot of molecular advances in the field, including the description of CALR mutations, performed this work. And Jennifer went on and took 3 patients who had a reduction in their JAK2 VAF in their blood, this is this figure here, and looked in their stem cells by sorting them into single cells and doing a molecular analysis. And the data she found is completely novel, And here you can see that for these 3 patients, there was also a reduction in their mutated stem cells. This means that ruxolitinib, because these were just ruxolitinib treated patients, is affecting the stem cells as well as the cells in the blood. That means that ruxolitinib, as well as other therapies that achieve this endpoint, but for this particular data, ruxolitinib is clearing disease stem cells. So what? So what we also were able to find, which is totally novel in this field, was that for patients who had a molecular response, so 50% reduction at 1 year, they had this better event-free survival. So we've seen that event-free survival, which is important to all of us, correlated with ruxolitinib treatment, with obtaining a response for blood counts, and with reducing the JAK2-VAF. We don't know which of those is more important, but each of them had showed a correlation. And over the longer time of the study, regardless of treatment, that obtaining a 50% reduction in JAK2-VAF reduced the patient's chance of having a thrombosis, a hemorrhage, disease progression, overall improved event-free survival, and that patients lived longer if they had this molecular response. So this particularly is important and provocative for all of us, but we will not be running away and including this in our standard therapies, and we'll talk about this in a few minutes. Many of you will have thought about additional mutations and doing wider mutational screening, and Jyoti, Billy Dunn and Joanna Baxter performed this analysis. We found that a proportion of our patients had extra mutations. This is shown in this fancy figure here, and we were able to test this in 172 of the 180 patients. This line here represents the JAK2 mutated patients, and these are all of the different mutations. Don't worry about the different colors, they just tell us what type of mutation they are. We found that the presence of additional mutations were associated with less likelihood of molecular response. So patients with a little asterisk above their waterfall bar here were those with additional mutations, and you can see that more patients who didn't have those asterisks are below the line. The presence of additional mutations, and especially one called ASXL1, which wasn't a very common one, were associated with less good event-free survival. An important benefit of ruxolitinib for patients, and indeed the type of patient I would really want to put on ruxolitinib if I had it available to me at Guy's Hospital, would be patients who have a big burden of symptoms. But what NICE and other reimbursement agencies want to know is, how durable is that symptom response? And we can't answer that, or we couldn't answer that until the MAJIC PV study. And here you can see that out to 48 months, patients with ruxolitinib had a lower symptom burden than those patients on the control arm. What about side effects? Well, we know well that ruxolitinib increases the risk of infection, and we saw that as highlighted in the red bars on this slide. There was an increase in shingles, that's what herpes zoster is, and other infections, but there were no deaths due to infections, and the number of severe infections, that's by grade 3 or 4, was not particularly increased. And you can see that actually sepsis was much more common for patients treated with on the control arm. What about other cancers? So transformation of disease did occur in both arms of the study. Skin cancer, we know, is a risk with ruxolitinib as well as with hydroxyurea, and it's impossible to say whether it's the previous hydroxyurea or just the ruxolitinib, but we know that this is an important thing to watch out for if you're treated with both of these drugs. But other cancers were not increased for ruxolitinib treatment. So, coming up to a wrap up now, Nona, MAJIC PV confirms our current treatment algorithm, but it also challenges it. It shows the benefits of targeted therapy for some patients and molecular monitoring. We've demonstrated for the first time that ruxolitinib like standard therapies, can improve freedom from blood clotting and also overall event-free survival in the second-line setting. And for most patients in this study, it was actually a third-line setting. For day-to-day practice, we showed that controlling the blood count is important regardless of what treatment a patient is having, and this correlates with event-free survival. And we've also provided some provocative data which is going to move the science forward in terms of reduction of mutated cells. We found no new safety signals, but it's important that patients are aware of skin cancer and infection risks. We have already used this data to support a reapplication in the UK for ruxolitinib with NICE, and in fact that meeting was last week. And this data will also impact other countries where ruxolitinib is not available for patients with PV. These include countries such as China, Japan, and Asia. The data support us considering routine monitoring for JAK2 allele burden, but this is really for discussion and further analysis. For example, if you're a patient sitting in front of me in my clinic at Guy's and you've got great control of your blood count, but your JAK2 VAF hasn't dropped, does that mean I should change your therapy? I don't think we know the answer to that at the moment. We have a new study called Mithridate, which I'm going to show on the next slide, which is another academic study. So this study shows how important academic studies are. Mithridate is a first-line study and it's supported by MPN Voice. And this is a call out really to say we must have other long-term studies. Please think about joining them if you're a patient. Please think about opening them if you're a doctor listening to this. And these studies need to have built-in, well thought about endpoints for diseases like PV and other MPN. So this is the Mithridate study. It's a study that we're carrying out with our colleagues in France, such as Jean-Jacques Kalajan. And here we're taking the data from MAJIC and moving it earlier in the disease treatment pathway, asking the question, is ruxolitinib better than either hydroxycarbamide or interferon as a first-line therapy for PV? And the endpoint here will be event-free survival, and we will prospectively validate benefit of JAK2 allele burden reduction. Who's eligible for this study? You're eligible if you've got PV, you were diagnosed in the last 15 years, treated for less than 10 years, and have high-risk disease. You're over 60 with a previous thrombosis or hemorrhage or platelets over 1,000, and you must have a raised white cell count, but you can have had that at any time. So I want to end here by thanking everybody who is involved in this study, and there were a lot of people. This study was funded by Blood Cancer UK, who funded a trials acceleration programme. There was an unrestricted grant from Novartis and free ruxolitinib provided by Novartis. But most importantly, I want to thank all of the patients and their families, as well as doctors, nurses and scientists involved. These are all the different sites that were involved in the study. And Nona, I think I'll stop here now and we can have some questions.
That is just amazing, and I want to share with viewers that I actually have had an MPN and PV since 1991. And when I was diagnosed, there was nothing like this. This is a real light bulb moment of the work that all the clinicians are doing to help us patients. And on behalf of the patients, Claire, and your team of doctors that have facilitated this study, I would like to say a huge thank you. But I have a question about ruxolitinib. I know it's available in Scotland, but it's not yet available in England. How available is it around the world?
Well, as I pointed out, and so did Tim Somerville to the NICE committee last week, England is probably, and Wales, the only country pretty much in Europe where ruxolitinib is not available for patients. I think we have to point out, though, that there are many countries around the world where ruxolitinib isn't available. I mentioned specifically China, that's a massive country, Japan, Asia, and these results will be used for that. And if we learn nothing else and get nothing else from the MAJIC PV study, it's really important to all of us who've been involved that patients would get access to this drug, because we think it's effective, and it's effective for specific patients. We do need to remember, though, that we are quite privileged in England, that if we do get this drug, and I'm really hopeful that we will, we'll be getting it for free. And across the world, many, many patients actually have to pay to get ruxolitinib, and it is an expensive drug.
That's amazing. And we have to keep our fingers crossed that NICE approve it for England now and for Wales. What about Northern Ireland?
Well, I actually think that Northern Ireland, they are following the SMC. And so I think they have access, but don't quote me on that. I might be wrong. You need to ask Mary Frances McMillan that question. But what I really hope is that patients will be able to have access to the drug. There may be some stipulations put on it, which is fine. It is an expensive drug. Many patients have other options, such as interferon or hydroxyurea, which are perfectly good drugs. It's just if there are patients who have failed these two options, we don't have good options. And this is why Tim and I were determined to slog it out with the NICE committee last week.
I think what this has highlighted is the need for these trials, the need for the studies. And I know that because we're a small cohort of patients, really compared with other cancers, that finding funding for them is often quite problematical. And that's why I think when MPN Voice are able to fund a study, it really helps the patients. But then we need the funding to fund the study. And I don't know if funding studies for MPN patients is getting easier or more difficult in this very difficult economic climate.
Well, I think as a trialist, I would say it's never easy to fund a clinical trial, and you need dogged determination and strong willpower. That, you know, the MAJIC PV study we started talking about in 2010. We launched the study in 2012, and it's taken us 11 years to complete it. So funding it is one thing, then running it is another. Funding is more difficult, but it's not impossible, and every penny helps. So for the Mithridate study, there is an annual contribution coming from MPN Voice, which is really important. And there are other benefits to that. So for example, in England, we have the National Cancer Research Network, which provides, let's rephrase that as the National Clinical Research Network. So it's not just for cancer, but this will provide infrastructure within hospitals. So if MPN Voice provides some contribution to a study, not even totally funding it, contribution, then the study is allowed to be supported by those resources in hospitals, such as mine and others. So that's really important. And the recognition of these trials and the recognition and provision of that infrastructure is important. So even if MPN Voice only provides £500 towards a trial, the actual impact of that provision is much, much stronger. And also disseminating results and sharing information and encouraging patients to think about trials and find out information about them is an important role for the charity.
Because we have another study that's going with the MOSAIC study.
Yes.
And I know you talked about how long it took, the 10 years that it took to get this MAJIC study from beginning to end. And I think, you know, we're waiting now probably till next year when we will have some really important news to share with the community on MOSAIC. So there are ongoing studies, and there must be a few in the pipeline, I guess.
Well, there are lots of studies. I mean, when I started 22 years ago as a consultant, there was only one MPN study on what we call the portfolio, which is basically the spread of studies that we have for patients. And that was the PT1 study, which started in 1997 and finished in 2017. So there's a 20-year study. And that study led us to really important biological findings as well as clinical findings. And we could maybe do a separate vlog on that if you like, Nona. But now there are over 20 studies on the portfolio for MPN patients. Some of these are what we call commercial studies, so they're funded by pharma companies, and some of them are academic. And we like to have a mixture because often the commercial studies allow us early access to a drug for when patients maybe don't have any other options. And some of the really exciting studies that are coming here, just to highlight to the audience, are all those agents that target calreticulin, so the antibody therapies. They are coming, and they're going to be open at Guy's and other 2 sites in the UK. So these are commercial studies. We would never be able to do these as an academic study, but we need to have a partnership between patients, clinicians, and pharma to do these studies and academic studies.
And one last thing, Claire, I'd like to raise. In a recent newspaper article, there was some quite negative comments about the use of hydroxycarbamide and the terrible side effects. And I don't think, for me personally, and as you know, I've been on hydroxycarbamide for a very long time. I think everybody experiences differently, but I really would like your reassuring voice that actually hydroxycarbamide, and you know, as I say, I've been on it for many years, has some very plus signs for treating people with PV and ET.
Yes, I think it's really important to emphasize that this study was done in patients for whom hydroxycarbamide wasn't really working, or it was causing side effects such as leg ulcers, mouth ulcers, skin cancer, etc. I think there is the temptation when one is writing a news article to write something that is sensational. And for the vast majority of patients, and there are thousands and thousands and thousands of prescriptions of hydroxycarbamide done for MPN, but also done for patients with sickle cell disease across the UK and across the globe. And it is still a very safe and effective drug for this disease, as is interferon, a safe and effective drug. And which drug a patient should have is really for a conversation between them and their clinical team. If the clinical team isn't sure, they'll probably have a discussion in a committee meeting or reach out to a colleague in another hospital, or the patient can reach out and have a discussion with someone else. So it's really about individualizing, but with an evidence base. So if you think a patient might need ruxolitinib because hydroxycarbamide is not working for them, or interferon isn't working for them, then here is the evidence for what ruxolitinib can do compared to staying on that treatment. So all of these treatments have pluses and minuses. There are some benefits for ruxolitinib in this study, but there are strong benefits for the other agents in the first and the second line setting. And often in clinical practice, Nona, if hydroxycarbamide wasn't working for you, we might try to switch you to interferon, or because we really think the two drugs are quite interchangeable as effective first-line therapies, we might decide to change anyway, because you might want to lessen your chance of skin cancer, or if you are a younger patient, you might want to think about having a pregnancy, and interferon is more effective. So I think we've got lots of data added to from this study about safety of these agents, but it's always important to read the package insert and understand the risks and benefits of the treatment that you're taking. But be assured your clinical team will be doing that too.
Thank you, Claire, and I'm sure that you've provided a lot of reassurance to patients, and this study is just so exciting for PV patients. And thank you for taking the time to share this and on this monthly blog. It's been a great pleasure, and I know will give a lot of pleasure to a lot of people out there. Thank you.
My pleasure. Thank you very much, Nona. Look forward to coming and talking to you about other research and other studies in the future. Have a good day, everyone.